Hey everyone, Dr. Pat and I would personally like to invite you to join us in our Grow My Baby program. This is week-by-week pregnancy and birth information developed from our experience of helping more than 4,000 women grow and birth their babies. All our links are on our website, growmybaby.com.au.
The information in this podcast is provided for education and research information only. It is not a substitute for professional health advice.
If you're trying to get pregnant or you are pregnant and you feel a little bit overwhelmed by all you need to know, then this is the right podcast for you. Welcome to the show. I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney. And this is The Kick, your expert-led podcast that delivers the essentials of growing a baby. Make sure you head to our website, growmybaby.com.au, to get some awesome free tools like our pregnancy knowledge checker to help you feel like you got this.
Well, welcome back, everybody. I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And we've got another Q&A.
Awesome.
We have so many Q&As that I just want to get a few episodes done so people can feel like they can have a semi-timely answer to their questions.
Yeah, because if you contact us with something at 36 weeks and we give you the answer like 10 weeks later, it's probably you had the baby, hope everything went well.
Yes, and it's a bit hard because we do big block recording sessions, so that's the only way we can manage it with Pat as an obstetrician gynecologist in a super busy clinic. Me, I don't know what I do, but I tend to have no time ever.
So absolutely. So we will record a few episodes in a row.
Yeah.
And hope these Q&A ones are useful to people. I think they're fun.
Yeah, I think they're fun too. I like listening to your answers. All right, let's have a speak pipe.
Perfect.
Here we go.
Hi guys, my name's Madeline. I'm currently 21 weeks pregnant. I have a question, and it is, are you allowed to ask for a different midwife during your labour if you are not getting along or have the same values and beliefs?
Fantastic question.
Such a tricky situation, isn't it?
Yeah, So in a standard setup in Australia, everyone's got a midwife looking after them throughout the birth, labour and delivery, but that's someone who's assigned to them, not typically someone who they've met before or has been involved in their antenatal care.
Yeah.
That's how things usually work in Australia. So, you can ask, but it might not be possible. We don't have enough midwives.
Yeah, there's a real shortage. I'm not sure whether this is the same everywhere in the world, but in Australia there is a real staff shortage in the midwifery area.
Yeah, so that just might not be something that can be done. I think a positive way of looking at this question is a reminder of the importance of make a birth plan. If our birth plans, we're always saying to people, keep them open-minded, include how you would go if intervention or change of plan is necessary, and open up at the start. Agenda item number 1 on the birth plan is, I understand birth can be complicated. I'm interested in the views of my carers, but here's how I would like things to go. And the more we tell people how we would like them to go, the more that person can say, fine, that's good. We'll do our best to bring that about.
Yeah, I absolutely love our birth plan because we go through it as if it's not a linear process.
Yeah.
And the birth process isn't linear. You've got to have, if this happens, these are the questions I want to ask.
Yeah.
If this happens, these are the questions that I want to ask. And if you can have that time with your midwife and just say, hey, I want to get on the right page with you. Can we just go and have a look at this birth plan? So
a really good birth plan can alert that midwife at the very start of the day. Here, I'm someone with lots of knowledge. I'm someone who likes things to be discussed with me, and here's my ideal approach to it. Great way to get off on the right foot.
And if they say, look, we're really short staffed, there's nobody else here, I'm it, maybe, and you can't get on the same page. Your partner, your birth support person, they might have to step up a little bit more. Yep. So that's another sort of plug for them to be learning all of this as well, so they know why you might be distressed or why your values aren't the same or you feel they're not the same as the midwife that's caring for you.
Yeah.
It's really important.
Yep. And it's certainly part of the job of the person who's caring for you to be aware if there's some sort of interpersonal conflict or major discrepancy in how you feel about things and respond appropriately.
I just want to say too, at any time in your pregnancy care and birth, you can always ask for a different provider.
Yeah.
Yeah.
Yeah, you can. Yeah.
Yeah. Some people feel like, they've started with one and therefore they have to
Stuck.
be wedded
Yeah.
wedded with that person.
No,
but
it doesn't really work that way. It's, you can choose.
Yep. All right. I'm going to read the next one, Pat. This is from Catherine. Hi there. Thank you for your pod. It seems to answer the questions I didn't know I had. I had my first baby 12 months ago via rotational forceps vaginal delivery. I've just listened to your most recent pod about vaginal versus C-section delivery. Dr. Pat mentioned the increased risk of surgery, relevant prolapse later on in life. I'm wondering if I would see potential signs of this now.
Okay.
Yep. And then my OB did give me the option of forceps or C-section when they realised the baby was in the wrong spot, posterior, looking up rather than chin to chest. And then she has a second question. But let's answer that and then we'll go on to the next question.
Okay. So I didn't mean to suggest that rotational forceps was necessarily inappropriate. Sounds like it went very well in your case. I guess what I was saying was that a known risk of rotational forceps deliveries is a certain type of damage to the pelvic floor that can commonly require surgery later on. But you wouldn't know that now. You wouldn't know or feel that now. It's something that happens years later. Yeah. And because of that as a known potential risk of rotational forceps delivery, some obstetricians don't do that or recommend against it.
Now, we've got a whole prolapse episode that we're going to record today. It'll be released in, around this time. So listen to that too, because I think what we'll go on to talk about is how somebody would know that they've got a prolapse.
Yeah, sure. So, if you had a prolapse right now, you would know. And we're talking with specific reference to rotational forceps, we're talking about damage to pelvic floor that may not be immediately obvious, but can come back to be a problem in the future.
And she says that her OB did give the option of forceps or C-section when they realised the baby was posterior and was looking up rather than chin to chest.
Yeah, I think that's good care.
Yeah.
Yeah. They say, look, here's the options.
Yeah.
And if you've got an obstetrician with the skills to do a rotational forceps delivery and feels they can do it safely and well, fantastic. Otherwise, some people might say, yeah, I understand you can get the baby out that way, but I'm concerned about the effect that might have on my body. I'd rather have a section, please.
And it's hard if your mindset is vaginal birth at all costs. Yeah.
Yes, and I guess that's why, through these podcasts and our program and so forth, we want to bring this discussion into the light of day so that people can have a think about it before it becomes an issue.
Yeah.
Certainly if you're there, fully dilated, OP, it's a difficult time to have a conversation about the pros and cons of rotational forceps versus cesarean section.
Yeah. You got to go into that situation already knowing the questions that you want to ask. Yeah.
I think so. Yeah. And I think I don't think it's overcomplicating a birth plan situation to encourage people to have a think about that in advance.
Now, I think she gives us a little hint on how the birth went, because the next question is, I'd also love to hear more positive stats about second vaginal births after a second to third degree tear and posterior babies. So I'm assuming from that she's had a second to third degree tear. Yeah.
I guess maybe, yeah. And look, that's that happens a bit with forceps deliveries. It can happen with a non-forceps delivery. So if we look at that as a separate question, and we say, if I've had a second or a third degree tear with my first baby, but I expect my second vaginal birth to go way better, then is it reasonable to have my second, third, fourth baby vaginally? And I really think the answer in a lot of cases is yes. If some damage has already been done to the pelvic floor, things have been stretched, but the tear bit was expertly managed, then I think it is reasonable to assume that because of that stretching from the first vaginal birth, that the other babies will come out much better. And then at the very end of the day, if I've finished my family if I've got any pelvic floor dysfunction at that time, I'll have it managed then.
Yeah.
Other people feel differently. Other people say, no, didn't appreciate that large episiotomy, or didn't appreciate that big tear, or didn't appreciate the 3rd degree tear, and I don't like the risks involved in that happening again. Therefore, I'll have future babies by cesarean section. And you got to personalise that the response to that. Depends what people are most interested in as the birth outcome and most concerned about of the negative outcomes. Yeah.
And it's a constant discussion. If you're thinking of becoming pregnant again, or you are pregnant, it's the discussion that you can have with your OB. Like, you just have to keep having that conversation, and until you feel like that's fleshed out and you can come to a really confident decision.
Absolutely, and this happens all the time. Lots of those outcomes that we don't like, in 3rd degree tears or trauma to the vaginal skin, it's a real first baby thing to happen. And it's a complicated discussion to have with someone the next time around, to say, yes, those things could happen again, but they probably won't. And then sometimes people say, well, what if they do? And so it's a conversation that needs a little bit of work. In most cases, if people have achieved a vaginal birth for their first baby, even one with intervention or even one with some pelvic floor trauma, they're still reasonably keen to have the remainder of the babies vaginally. And it's roughly true that the other babies will come out easier.
Yeah. Good luck, Catherine. I think you're on the right track there with your questions. Patty, will go on to SpeakPipe.
Hey, Dr. Pat and Brigid. Thanks so much for your podcast. My name's Jessie, and I am looking at getting pregnant. Currently, I am taking some Ponstan and Nurofen and things like that, the non-steroidal anti-inflammatory drugs for pain. And I'm just wondering what your thoughts are when you're trying to conceive. Thanks.
Yeah, great question. I don't have a problem with anti-inflammatories and trying to conceive. We do prefer people don't use anti-inflammatories in pregnancy. Yeah, there are some known risks of doing that. The odd dose here and there doesn't seem to be a problem, but 0 is a nice, easy message. And using anti-inflammatories, certainly using them regularly when you're pregnant is not a good idea, but in the trying to conceive phase, not a problem at all. What
about in the 2-week wait from, potential conception to knowing you're pregnant?
I would just stop with a positive pregnancy test.
Right.
I think that would be very reasonable.
Yeah. And just taking anti-inflammatories and Ponstan, that's a typical sort of period pain.
Yeah, it's probably for pelvic pain.
Yeah.
So, we don't know this person's circumstances, but they're probably taking it for pelvic pain, perhaps endometriosis. And I'm very, very comfortable with that being part of a regimen for controlling those things, as well as paracetamol, as well as wheat bag hot pack, as well as exercise, as well as some hands-on therapy, as well as some big gun pain relievers if necessary. And the time to reassess what we're taking is when we get the positive pregnancy test.
Good. All right. Excellent. I've got one to read. Anonymous. Hi, Dr. Pat and Brigid. Firstly, thanks for all your hard work you've put into the podcast. I would love to hear about secondary infertility and why this happens and how common it is. I recently seem to have heard many people mention how they struggle to get pregnant a second time, and I'm worried that this might happen to me now that I'm 35. Is this something I should be concerned about? For reference, I got pregnant at 33 within a couple of months, had 1 miscarriage, then pregnant 6 weeks later and had a successful pregnancy.
You're listening to The Kick with Dr. Pat and Brigid.
How many times have you Googled something about your pregnancy?
When I was pregnant all the time, Dr. Pat.
Yeah, we get it. You may be confused or overwhelmed. It's normal to want information, but where's the reliable stuff from experts?
Yeah. Now, if you like our podcast, Dr. Pat and I have developed an online program to help guide you through whatever stage of pregnancy you're at.
It's taken us literally 2 years to put it together.
2 long, hard years, wasn't it?
But, it is a game changer in how pregnancy information is given.
Now, how it works is you get to sign up at whatever stage of pregnancy you're at. Like, so you could be pre-pregnant, in your very early stages of pregnancy, late pregnancy, preparing for birth, or maybe you've just brought your baby home. And you get lots of information around that. And then you also get to join our closed Facebook group.
We've called in all our contacts too. So we've got a dietitian, anaesthetist, physiotherapist.
Sonographer.
Yeah, who else? Paediatric nurse, obstetrician, mother of four.
Oh, just all the people you need to hear from.
So if that's you, come and join us at www.growmybaby.com.au.
Secondary infertility, great question. Secondary infertility is, infertility being experienced by someone who has actually had a baby before. It's something that I'm not sure whether we're seeing more of this than we used to, but I think it's something that is probably going up in its incidence as the age at first birth goes up, because if you get a lot of fertility issues are age related. And if you have your first at 36, then by definition, you're going to be older when you have the second, and older again when you have the third. And so more people are still trying for another baby as they come into their late 30s, perhaps 40s. Yep. So if we accept that some of that apparent secondary infertility is in fact age-related, then that explains, I guess, a lot of it. The way we tend to approach it clinically is to do what we usually do: take a careful history. How long did it take to get pregnant the first time? Is this the pregnancy we're trying to have now? Is it with the same partner? Does the woman have pelvic pain with intercourse, things that suggest that there could be something that needs surgical correction? Is the woman ovulating? Careful attention. Are you at a different body weight now than you used to be? And for my own benefit, in my own brain, I dumb this down, probably too dumbed down for the patient, but in my brain it works. We need sperms. Are they there or not? Tick. We need eggs. Are they there or not? And we need a safe place for them to get together inside the woman. Has that been established? And then what we tend to do once we've sort of ruled out a missing ingredient is say, fine, we're now going to try at the perfect time of the month for a set number of months. If you're pregnant, fantastic. If you're not, we'll look at some reproductive assistance.
And I think secondary infertility comes as a bit of a shock to people. Like even when we got together and there's a 6-year gap between my second and our third, and I didn't expect it to be any different. But you, as the obstetrician in the room, went, okay, well, you're a little bit older.
yeah, I guess that's just the way we're trained to see problems. But
but I would have been shocked if I wasn't fertile. But I suppose that's what people have to deal with. They're like, well, we got pregnant really easily, quickly. She got pregnant within 2 months, even though with a miscarriage she still got pregnant 6 weeks later. So, that's a reasonably quick time frame.
Yeah, that's right. So I remember being impressed with your optimism at the time, and I like to see that in patients. I like to see people who've had no fertilities before fully expect to get pregnant again, even in their late 30s. What I do think it's important is that people are aware that the longer it takes, the more likely that there is to be a problem, and that some of those problems are fixable, and we don't want to just try forever and use up time that we could have been helping you.
Yeah. Well, this caller's 35, but say you're 39 and you think, oh, well, I've been pregnant before, I'll just keep trying, and just keep trying for like a year.
Yeah. So that old thing, we've covered this elsewhere in the podcast, but that old thing about, try for a year before asking for help, it's a bit different if you're older, if you've got pelvic pain, if you've got a history of infertility, or if you've got an irregular cycle. Those things I would be getting sorted out up front if I was trying to have a baby at 39.
Do you want to answer a question about cholestasis?
Yeah.
All right, Pat, let's go on to another speak pipe.
Hi, Dr. Pat and Brigid. My name is Ashley. I'm currently 16 weeks pregnant with my second baby. I would just like to know more about cholestasis. I had it with my first baby, but I got it towards the end and I never really understood what it was. I was just told I had it and that they were going to induce me because of it. So I'd love to know more about what it is and, the risk factors and how common it is and what causes it, especially as I'm coming into my second pregnancy, just being more aware of what I could potentially get again and what it involves. Thank you.
Is this a bigger episode?
Yeah, maybe.
Yeah.
It's a really good question, because the caller says I'd like to know more about it, and so would we.
Yeah.
We really don't know enough about this condition. Certainly we don't know what causes it. It's a form of rare but not terribly rare liver dysfunction that happens during pregnancy called obstetric cholestasis. It often presents as severe itch during pregnancy, and if on blood tests we can see that the liver's not working properly. When I first trained in obstetrics, this was not thought to be a very important thing. And then later on, the connection between obstetric cholestasis and poor pregnancy outcomes became clear, including a rise in the risk of term stillbirth in women with obstetric cholestasis. So it's become quite common to test for it if the woman's got itch or if she's had obstetric cholestasis before, to try and treat it. There's a treatment. And then to avoid the risk of term stillbirth by getting on with the birth earlier once we've reached a reasonable maturity of the pregnancy, perhaps 37 or 38 weeks, to just cut that risk out.
And is it just, how does it present? Is there itch all over or?
Yeah, there are a number of different itches in pregnancy, and they all need they've often got a pattern. So some itches, it's on the palms of your hands and the soles of your feet. Other ones itchy on the belly. But serious itch in pregnancy is not a normal thing and needs assessment.
All right, I think that we should do a whole episode, itch in pregnancy.
It's not a bad idea.
When you've got an itch, do you need to scratch it?
Yep. Obstetric cholestasis is really interesting.
Yeah. Thanks, Ashley. Hopefully we'll get that out before the final sort of weeks of your pregnancy, so you have a bit more information.
All right, it's on the list.
It's on our list. Another speak pipe for you.
Hi there, my name's Vanessa and I'm 18 weeks pregnant. My question relates to the results of the NIPT test and what actually gets sent to my obstetrician. So my husband and I have decided not to find out the gender of our baby, but I just wanted to know whether or not the report that gets sent to my obstetrician actually includes the gender on there. So does my obstetrician know the gender of my baby, even though I don't? If you could answer that question, that would be really helpful, because then I'll stop reading into everything he says and trying to catch him out. Thanks so much. Bye.
Terrific question. Well done. Yeah, they do give us everything. And just because you say you don't want to know the baby's sex, the test finds it out, because the test looks for the number of X and Y chromosomes, and that's because there are reasons to look at that. There are disorders of chromosome of sex chromosome numbers. So you know there's not just XX and XY. You could have too many X's or too many Y's or not enough X's, and those are conditions that are relevant. So that's a really great question.
Yeah, I can see how someone would read into everything.
I know, right? And people.
Can I ask first? Have you ever accidentally
blabbed you once?
Oh my God.
No, well, yeah, no, I don't know that I've ever blabbed by accident, but I did tell someone it was a girl and it was a boy.
Oh.
Yeah, because I just got it wrong. This is before NIPS.
Yeah.
When we were just using ultrasound.
Right.
So I took a number of ultrasounds and was convinced it was a girl and it was a boy.
Wow.
This person might be listening and might remember that this was 15 years ago. And the baby came on New Year's Eve.
Whoa. Sorry, what did she say? She wanted a girl.
She was happy. She wanted a boy.
She wanted, right.
Yeah, so she was happy.
But had she set everything up, like the nursery? Oh my Lord.
Yeah, probably. Well, she already had girls, so I think that maybe she just was using the
same set of nursery and clothes. Yeah.
So but blabbed, I don't think so. Except that to answer the question, they send us everything because there are disorders of the number of X and Y chromosomes. So the test needs to look at XY chromosomes.
Right.
Even if you tick the boxes you don't want to know, the test still reports that to the requesting clinician. So the report says that the test is apparently normal for trisomy 21, 13, and 18. Plus, there's a couple of other things that can be tested for, and it'll have the report for that. And then in the lab I use, it's on the second page.
Yeah, right.
And on the second page, it'll say, here was the sex chromosomes. And what the lab that I use, on the first page, it says that it was all fine, and you've got to look at the second page to find out.
Yeah, right.
But we look after a lot of people, and I don't. Even if I have found out, I don't remember what someone's having.
Yeah.
So if I'm doing an ultrasound, we try our best not to say him or her. But if I said either, it's not because I know. It's because it's just it's a slip of the tongue.
And the obstetrician or the clinician might actually just refer to the fetus in a gender anyway.
Yes,
by default.
by habit.
Yeah, by habit.
Yeah, and a neutral term like they or something is probably better to use.
Yeah.
Yeah. But you do try and sort of catch them out, because remember when we went to Melbourne to have a scan for Sully, and they said, and we said we didn't want to know, and then the extremely skilled ultrasound provider, who's an old friend of ours, the one image where where you could have seen, he sort of he'd sort of deliberately held the probe so that the cord was hanging down over the and so he couldn't tell, and he knew that I was trying to find out.
Yeah.
Even though I didn't want to know.
Yeah,
I couldn't resist.
He did say at a couple of points, Pat, you might just want to turn away from the screen.
Yeah. But I thought he was deliberately trying to hide it from us.
Yeah.
But we find out, and there's nothing else on there.
Yep.
Yeah.
A couple of times we've been asked to send the sex of the babies, the result, to like a baker or something.
Yep, for a gender reveal. Yep.
Yeah. So we do try to keep everything under our hats. All right, Pat, I've got another speak pipe.
Hi, Brigid and Dr. Pat. I'm a massive fan of the podcast, and I'm so happy that you're back making more episodes. So my question is, I had a daughter last year. She was 4.2 kilos, but I'm quite tall myself. Her labour was 36 hours long, with contractions every 3 to 5 minutes and lasting for up to a minute each. And they're pretty fierce contractions right from the start. It took a while to really get anywhere, and after a while they did figure out that she was in a posterior position with her chin tilted upwards, and she really wasn't going anywhere. So I did end up in theatre with quite a big episiotomy and a forceps delivery. But it does make me wonder whether a subsequent birth, if the baby is in a good position, would I potentially have quite a short labour, with how well I was contracting to start with? Like, if she hadn't have been in such a poor position, potentially it may have been quicker, or because she was big, with the next baby potentially being bigger, would I be likely to have the same scenario again? I don't know. I've just been thinking about it and I'm really not too sure. Thanks so much.
Fantastic. Well done for getting in touch. Tricky one.
Yeah, it is tricky.
Tricky one. So we've sort of talked about this issue a bit elsewhere, but new pregnancy is a new pregnancy. There were two obvious factors looking back on that very long labour that contributed to how long it was and how difficult it was to get that baby out. The first one was that it was a 4.2 kilo baby. That's right up top end, and secondly OP's posterior position. So babies sitting there trying to come out, but looking up at the ceiling instead of down.
She
pushed
it out though.
Well, it sounds like with a forceps, is that right?
Yeah, forceps and a large episiotomy.
Yeah, so tricky one. So the question, of course, is what's the best thing to do next time? And the answer is hard to know.
Mm.
Yeah. Like all good questions, the answer is yes and no.
Mm.
So things to take into consideration next time is that, let's say, for example, the only issue was the OP, and the next baby in the early stages of labour was known to be in a much better position, then you would expect that labour to go much faster and much better, and probably that baby to come out without even requiring instrumentation. And that's something that can be looked at and felt for or scanned on ultrasound in the early-ish phases of the labour. But remember, looking at that in advance of the labour is not that useful, because we want to know what positions the baby is in when the labour's going, not 2 days before. 2 days before, the head might be able to pivot. It might look OP 1 minute and OA the next.
Right.
You know, looking for front ways 1 minute and looking back ways the next. We're interested in the position in labour. Yeah. And then and the size is highly relevant as well. So the things that something I would take into consideration if I was considering a second vaginal birth after that birth would be how big's this baby thought to be, okay? And even taking into consideration the known issues with inaccuracy of a term ultrasound. We should be able to chart the growth of this baby over the course of the pregnancy and work out at least whether we think this baby is roughly less than 4 kilos or roughly more.
Yeah. If the baby's less than the 4.2 of the previous baby, but you would just sort of think that would proceed. But if she has an ultrasound that is predicting that the baby is bigger than 4.2,
yes,
because sometimes subsequent babies are larger.
Can be.
Yeah. As a rule, are they larger, or is that just by chance?
No, just by chance. Yeah.
So if the baby's more than 4.2, predicted to be more than that, what do you think her options are then?
Well, then a careful discussion has to take place about how last time really went. Did we get away with last time without too much physical and mental trauma? Did the forceps delivery involve anal sphincter damage? And all of those pieces of information we would need to know if we were going to try and have yet again a very large baby vaginally.
Do you talk to people much about, I know that on the internet and everything there's a lot of optimal fetal positioning and do you think that matters? Like, you know, is there anything anyone can do coming into the labour?
I don't think so, really. I think this is mostly fetal behaviour.
Yeah, right.
And I think it's like the discussion we have with people about a breech baby and how to get the breech baby to turn around. It's very tempting to think that there's something you can do, sit up, you know, spend time in the bath, jump, a certain type of exercise, whatever that might encourage breech baby to turn around. But in the end, it's fetal behaviour. The breech baby will kick itself around if it wants to and won't if it doesn't. Yeah, and I think positioning at term is fetal behaviour and a bit of good or bad luck. I don't think there's anything we can do to help with that.
Wow, there's whole programs on how to get your baby in proper position. And
yes, I get that, and I think that those programs we should concentrate on things we really can control, like body weight at term, being a non-smoker. But can we really influence? I think the evidence is lacking that we can really influence the fetal position on the day of the labour.
All right. Well, good luck. I'm sure you're going to make some really great decisions about how your next birth is going to go. And yeah, we're here cheering for you.
Good luck.
All right, people. Well, that is another Q&A done. We had some really fabulous questions. And again, we just love you sending them in. So keep them coming.
Yep.
And it really shows us what information we need to be helping you with.
Absolutely. And it helps us to provide information that's relevant to the people who are listening.
Yeah, and really directed. All right. Well, have a really great week and we'll see you next week.
Talk to you next time, everybody.
Bye for now.